of the University of Wisconsin. You may have seen Ed online. He frequently answers patient questions on Facebook groups and Inspire. He's a scleroderma patient who's in full remission. He's extremely dedicated to advancing research and is particularly knowledgeable in ANA and antibody testing. We hope you've all had taken the time to watch Ed's YouTube presentation. We'll be focusing on the information that was shared in that. If you have questions to add we have some that were previously sent to us that I'm going to read, but if you have questions you'd like to add, there is a chat box that you can type them in, or you can just flag us down if that's easier. We just want to be respectful of Ed's time and try and get as many questions answered as possible today. We'll try to get through them all. As a reminder, the Scleroderma Foundation in no way endorses any drugs, treatments, clinical trials, or studies because the manifestations and severity of scleroderma vary among individuals. Personalized medical management is essential. Therefore, it is strongly recommended that all drugs and treatments be discussed with the patient's physician for proper evaluation and treatment. All right, so Shelly, I wanted to thank for setting this up with Ed. She invited Ed to come back again and talk about this. So we really appreciate that, Shelly. And I really wanted to give a shout out to Jamie, who helped set this all up through Zoom and is my technical person that I rely on. So thank you so much, Jamie. Shelly, did you have anything to add before we tell Ed to take it away?
Well, I think I'm excited for this. Ed, it is always so good to see you. And what a great way to see you again. We didn't have to have you come all the way out, but then I know when you come out, you go visit your daughter. So,
actually, my daughter moved from Portland, Oregon, back to Portland, Maine area. She only lives in Portland, but the good news is 40 some states have Portland, so she has a lot of flexibility for the future. But unfortunately, she just had her first baby about 6 months ago, and we can't visit. So that's a real problem.
Congratulations on the new baby.
Thank you.
Soon you'll be able to hug that little one. So thank you, everyone. It's so good to see everyone. That's all. Thank you.
Yeah.
Awesome, Ed. Well, I know you had something you wanted to share, and then go ahead and then let me know when you're ready for some questions.
Okay, sounds good. This won't take long, but I wanted to just give you a status update on how many people are currently on our protocol. And by the way, I started about a year ago referring to this as pulsed plasma exchange. You'll see that more and more in my writings. And when I start publishing additional follow-on research, that's the phrase we're going to introduce. And there's a couple of reasons for that, but I'm using it because it describes the nature of the protocol. This is not typically how plasma exchange is used for a lot of disorders. So hopefully that can at least get clinicians to ask more about it because they're not quite sure what it means. So anyway, but it's also highly descriptive and a standard use of the term for pulse treatment. So what I wanted to share is, as of today, there are 10 people who have started on our pulse plasma exchange recommended protocol. Of those 10, one person tried starting with venous access, and it was pretty clear that wasn't going to work. So she has stopped and suspended until she can get a port implanted, and she's still working on getting that done. There's a second patient which I have not been in contact with in the Phoenix area, who, for reasons I can go into, the place that she was having plasma exchange done is controlled by nephrology, the kidney people, and they're kind of only used to doing this using central line catheters, which are totally unsafe and I strongly recommend against for this kind of situation. She had one round doing that, but is also looking at other solutions. And I haven't talked to her, so I'm not sure what her status is. But 8 people, as far as I know, are actively on the protocol. The longest time period is me, obviously, 27 years at this point. The second longest will hit 3 years in February. I think she started. And then with it, she's in Europe, and all the other patients are in the US. And the time people have been on is mostly in the 6 months to 1 week range. A person just started last week. There are 2 other people who are highly likely, I think, to go on the protocol. One I thought might be here is a person many of you know who has literally failed every treatment that exists, including stem cell transplants. She relapsed and is looking at trying it, and given that everything else has failed and then her insurance covers it, I think extremely likely that she will be able to start with no problem. And the other one I'll know more about next week. I was contacted by a doctor who's actually head of pediatric cardiology at a major university, and his now 11-year-old daughter appears to have this, and he approached me to talk about it. We're going to talk more next week. Whether they'll decide to do it or not, pediatric plasma exchange is a little more challenging. I don't know, but this is one of those situations where if it makes sense, he has the clout to certainly get that initiated. Oh, one of the patients is who is on the protocol is 15. So we're seeing a complete age range, a wide variety of antibody types and things like that. So I think that was it. I just wanted to give you an up-to-date, and I had to go count them because I wasn't sure at this point. And I guess one other thing that's probably pretty important. One of the doctors involved in this has indicated a willingness to talk with other clinicians if they are interested. Her experience is, is under a year, as is all the other patients, but it's been going well with the patient. And so if any of you get into a situation where you have a doctor who would like to talk to someone who's been dealing with this, the doctor can contact me and I can provide the contact information. I am not allowed to provide it other than to a physician, which I will totally honor. I think that's all the updates.
Awesome. Thank you so much, Ed. So I guess I'll start with the first question on here. Do you see a clinical trial for pulsed, is it pulsed TPE or pulsed plasma exchange? Do you get rid of the T totally?
Yeah, I'm using, even though it's being used for personal protective equipment, I am using just PPE for simplicity, a pulsed plasma exchange, just so you know. And I'm starting to refer to that in anything I'm writing online.
Okay.
That's a very good question.
Yeah, clinical trials for it starting soon.
So here's what the current plans are to get toward that. Right now, every one of these patients is on exactly the same protocol, even though this is not an organized thing. This is individual decisions of physicians to try it. But since they are all on the same protocol, it provides a superb opportunity to do a much better case series than is often done. And what I'm planning on doing is I will probably January, early January, will submit a proposal to do a case series poster at the American Society for Apheresis meeting that's coming up in May of next year. I actually presented at that same conference in 2016 the initial version of what's now the published review. And there's no question that it would be accepted there. Once I do that, that will be in print. It will be in print as a poster or a presentation. But the standard way a lot of people do things in the research world is they start with a presentation at a conference, and then they go from there to submit for publication. So my current plan is to do that. That'll get it in print by May, and then to try and do a full-blown, up-to-date case series, which my first choice is to submit to the Journal of Scleroderma and Related Disorders, which is the main journal in this field and where my review is done. And so once a case series with a dozen people or whatever is published, then I think we will be in a position to where a clinical trial is likely to be something that we can go towards. I do know that some of the physicians who have looked at it are open to doing a clinical trial. And realistically, all that is needed is probably a clinician at a major university who's willing to take the lead as principal investigator. I've already talked to the two main companies that provide the equipment, and I think it'll be pretty straightforward to get funding for the research. So we're close to that point, but if we get a strong case series with a variety of patients, variety of antibodies, and with good results, that should stir interest. So hopefully 2022 would be the timeline for an initial clinical trial using this specific protocol.
Okay, thank you. Next question on here, and I have people sending me other questions. I'll get to those. Just, I'm gonna go down this list real quick here. So after having seen your personal growth and progress with this treatment, has your rheumatologist recommended this treatment for other patients as well?
That's an excellent question. In Madison, University of Wisconsin-Madison is where my appointment is and so forth. There was a scleroderma specialist here, and he just retired, and they actually don't have anyone. The rheumatologist that I see who formally orders my prescription has no expertise in the area. She's not comfortable doing it for that reason in terms of talking with doctors, but she's told me she's open to trying it. And I know of one patient who will be trying to initiate plasma exchange locally. So I think there's a pretty good chance it'll become more common. So I'm having a little problem that my computer is constantly trying to interrupt, thinking I'm trying to talk to it in Siri. So I may have to figure out a way to turn off that feature. It's quite annoying. But anyway, so my physician is open to it. She has not ordered it because she sees basically no scleroderma patients. But I think anyone here is likely to be able to get it. And I know of one patient who has an appointment in December where she's going to try and initiate it.
Awesome. What laboratory markers improve with this treatment?
Good question. We don't have a lot of laboratory experience where we've looked at that. We have data, but I actually haven't looked at it much. I can talk about my case because it's published. The two things that we saw of objective laboratory data in my part, probably the most important is my lung functioning. So I have centromere antibodies, and then as those of you who have this knows, with centromere antibodies associated with the limited cutaneous systemic sclerosis, the primary risk is pulmonary artery hypertension. 20 to 25% of patients do eventually get that, usually after many, many years, not always. The disease, all variants are worse in males than females. The downside of being a feminist is all I can figure. But anyway, I actually was developing or heading towards that pretty rapidly. And the key measure you look at when you're looking at potential development of pulmonary artery hypertension is a measure called DLCO, and I won't go into it. My DLCO was down to 68% of normal. And that's not quite at the point where they would initiate doing like a right heart catheterization to look for it, but anything below 70% becomes concerning. And so I was realistically probably headed for that complication within a year or two at the rate I was progressing. That marker immediately stopped going down once I went on the protocol. And while it took a number of years, it gradually reversed and went totally back to normal over about a 4 to 5 year period. So that's the most powerful particular direct marker that would be commonly looked at in systemic sclerosis. There's a lot of, some of the research in the past has shown improvements in lungs functioning and things, but this is the first time we've seen that. The other direct marker, or the other marker where we saw objective improvement, is an indirect marker, and that's a measure called SED rate, or ESR. Sedimentation rate is a general marker of inflammation. Lots of things can cause that to be elevated. It's kind of like CRP, another measure of inflammation. My ESR is typically elevated a bit on average in patients with scleroderma, less in limited than in diffuse. And mine was never abnormal. But one of the things that happened over an 18-month period is it dropped from where it had been to a much, much lower level. That measure happens to be highly correlated with red blood cell clumping, turns out. So that's a pretty good marker, and we actually have one other indicating that one of the effects of the protocol was showing reduction in red blood cell clumping. I have more recent data actually showing reduction in overall blood viscosity that will go in a follow-on to my case report that I'm working on. The other patients we have not analyzed their data on, and that's my fault because I've been swamped doing other things. I have multi-years of data from the patient in Europe. The patient in Europe, by the way, who's been on almost 3 years, she has a rare diffuse antibody, U3RNP, and she went into full remission after about 9 months and has been there ever since. So, and I suspect some of her markers are probably changed objectively as well, but I have not been able to, or I haven't had the time to look at them. The one thing I will measure also mention, which is a little tangent, is both she and I stopped our treatments because of COVID for about 2 months. And as I knew would happen, I wasn't sure the exact timing, I started to become symptomatic again, and she did as well. And that's totally reversible, that's gone. I know that having tried it before, but this kind of emphasizes that as this is a chronic disease, this is a protocol that has to be continued permanently. And we now have another instance where somebody went off it, started becoming symptomatic, and went back on. And as far as I know, her symptoms are gone again. So kind of an interesting thing. I was going to mention that and I forgot earlier. So.
Yeah, that was one of the questions in the chat was, is this something you have to do for the rest of your life once you start it?
I think the thing that people miss, and actually one of the researchers, research studies we reviewed for the comprehensive review, the idea, there's exactly one treatment that has the potential to be a one-time treatment, cure the disease, and you don't need anything again. That is autologous stem cell transplants when they work, if you don't relapse. And that's a subset of the patients are going on 11 and 12 years now and truly seem to be cured. Every other treatment, I don't care what it is, it's a chronic disease and you need chronic treatment. And I think that's important, something that doctors are not always good about, just telling people up front, if you try whatever it is, CellCept, if it seems to be working, you have to stay on it. You will regress if you go off any existing treatment that I'm aware of, with the possible exception of successful autologous stem cell transplants. So absolutely, yes, it has to be continued.
Thank you. Another question in the chat says, I've read and heard that it is suggested to start treatment in the early stages. With mild symptoms so far, how mild is too mild to start or request treatment?
That's a great question. So first of all, the general, this I put in the, I think in the review paper. The reality is I can't think of any disease where somebody says, you know, the best thing we can do is start this really late in the disease process. I really don't care what the disease is. You're never going to hear that. So any treatment is likely to be more effective earlier than later. So there's nothing magical about that. The question of when to start is a great one. Let's assume for sake of discussion that it turns out the protocol does what it appears to, we hope it will, which is interrupt the disease process at an early stage, allowing the body to recover to the extent it can. I mean, if you've had gangrene and lost a finger, it's probably not going to grow back. But if you've been dealing with symptoms like GI, that may heal over time. It certainly did with me, and it does with patients who are successful with stem cell transplants. So at what point would I suggest someone try that if they can? It's a trade-off. I mean, I really have never said, you know, one of the things you should consider doing, it's just great fun, is going in for plasma exchange. You know, you get to watch a fun adventure movie, chat with a nurse. It's just not something, it's really not that bad to go through at all. It's pretty straightforward, but reality is it's not something that's, you know, you would want to do if not necessary. My general recommendation to people is, because it seems to be effective at reversing things if you don't have major irreversible damage, it's really a trade-off. It gets to the point where you're having severe symptoms which are causing difficulty with lifestyle or things. In my case, my most severe symptom was severe GERD. I was also severely chronically chilled and other things, but I never developed digital ulcers. I could have probably, but I was on 80 milligrams of Prilosec, as it was called that in those days, omeprazole, and it wasn't even working. So, so given something like that, it would be a no-brainer. If your only symptom is really mild Raynaud's, kind of at the level of somebody has with primary Raynaud's, which a lot of, especially young women develop, I probably wouldn't recommend it. This is a very, very low risk protocol. It's not 100% risk-free, but as long as you use fresh frozen plasma, you don't have allergic reaction risks, except in like a once in a million case. But still, you know, it's not something that's totally pleasant to go through. So I would generally recommend to someone, if it's something that isn't affecting what you are wanting to do, it isn't really painful, you can still do what you're wanting, it doesn't affect your job, your whatever sports you want to play, and it's just annoying, I probably wouldn't recommend starting it. So once it gets to the point where it's affecting you in a way that you don't want to be affected because it's modifying or restricting what you can do, or it becomes painful, that's the point I would recommend starting. Great question.
You may have kind of answered this a little bit, but maybe you can expand on it. In the chat, someone says, how can you determine if you may be a good candidate for the treatment? Are there specific things to look at?
That's really a very good question. And I mentioned that there's this one person who I thought might be on, some of you know, who has literally failed every treatment. And there are doctors out there who have told patients, this is a last resort because they think it's dangerous, although they freely prescribe immunosuppressants like Cytoxan, which are extremely, you know, dangerous comparatively. The reality is, there are certain things we know that plasma exchange really is not effective. So if you have late stage renal disease, this has been tested, it doesn't really work. Much better treatments where you can deal with that earlier. But we don't really know at what point you know, things are irreversible. But the good thing is, because it is extremely low risk, even in somebody who's really late in the disease process, there's probably no reason not to try it, except for in our protocol document, there's a very specific list of contraindications, which are pretty rare. But other than that, there really is not anything that suggests you should not consider trying it. It's one of the things that will be an issue, and we talked about that, and we're learning more about, is venous access. I mean, one of the things that I knew would be the case is if somebody has really, really bad skin changes where you can't get an IV into them or whatever, they're going to need a port implanted to do that. And a couple of the people who started recently just went in, were evaluated, and they were told, you're going to need a port. So they had a port surgically implanted, which is not a big deal. We're not talking about catheters. These are very, very low risk, easily tolerated. You can go swimming afterwards and things. That's what we're talking about. It makes it really easy to do this rather than venous access. But barring that, there's really, you know, pretty much anyone is a potential candidate because it's so low risk. I mean, it's the argument really becomes, why not try it? One of my co-authors and colleagues, who's an immunologist, happens to be expert in COVID, by the way. His thought is he can't imagine anyone trying autologous stem cell transplants. Those still carry about a 3 to 5, 10% mortality risk just from that, without at least first trying this. And that's his, recommendation. I never would or do recommend anything in terms of specifics for patients, but he's just puzzled why people would not first try something which is at least safe and has the potential to, if our hypothesis is correct, interrupt the disease process at a very early stage before the damage to the lining of the blood vessels occurs, which then leads to fibrosis and organ damage later.
I have two questions about ports. One is, can you utilize an existing port, or do you need to use the specific one mentioned? And when you use a port, is the return also through a port?
Excellent questions. So there are a number of implanted ports that people use for a lot of things. Vortex port is a pretty common name. Power port is another common one. Both of those, the vortex and power ports, come in either what are called single or double lumen. So a single lumen port means you can get one IV into it. A double means you can put two. You do need two needles to do a plasma exchange. So there's a return as well. There's another port called power flow, which is the only port that's formally approved for therapeutic apheresis. That's a single lumen, so you can't do both. The reality is what will work for a lot of people is they can use one port for access and use normal veins for the return. So the size of the needle required for access, it's large enough to where you need something, basically, the term is antecubital is the main vein, but it turns out, some of you are nurses can tell me there's two other veins on either side of the antecubital that are pretty much equally large. Those can be used as well. So for access, if you don't have a good antecubital or these other two, you're going to need a port for access. But the return is a pretty small, flexible butterfly needle, which you can do using normal forearm veins. I don't think you could use back of hand readily, but lots of veins are big enough for that. So it is totally feasible to use a single port. So if somebody has a single port and they have veins good enough for the return, and IV, nurses at infusion centers can quickly evaluate and tell you whether it's likely to work. Perfectly fine to do that. And if you were to use the power flow, which has the highest throughput rate, you would have to have a regular vein for the return. On the other hand, if you're getting it implanted from, just for this, probably you would want to go with a dual lumen, because frankly, it's a lot less painful and a lot easier. And the minute you're using a dual lumen port, it's a little slower, so it can slow things down a bit versus a really good vein or power flow. But there's certainly no reason why, if you have an existing port that's being used for like IVIG or infusions, in most cases that could probably be used for access. There are some ports that are not capable of the flow rates, and I'm not an expert in this area, so you'd have to check, but you definitely can get by with one port in most cases, as long as you have a reasonable size vein for the much smaller return needle.
One question regarding ports is how long do they last? I mean, do you do replacement ports often?
Oh, great question. So I'm going to drop back to the moment of the pediatrics case. There's a 15-year-old on a port now, and there might be an 11-year-old in the future on it. The 15-year-old may be is likely female. She's likely to be pretty much full grown at that point, so she'd probably be similar to an adult. 4 to 5 years is pretty common with these implanted ports, is my understanding. I don't know with a power flow, that's a newer port, but these things last a long time. The 11-year-old would probably need to upgrade to at once, probably twice before she was full grown, probably every 3 years. I actually talked to I was at a treatment on Monday, and I talked to knowing that there's going to be a discussion for an 11-year-old. And they said probably you'd have to do that about twice before she go to one that would last 5 years-ish that you normally get with these. So they're pretty long lasting, and the surgery is quite minor, pretty easy to do. And I don't know, do any of you have ports? So, you can kind of tell me what your experience, I mean, if you've had them for a while, but usually what I've been told is it's not that big a deal or procedure to get these kind of ports installed. And you can literally use them the same day, which I strongly do not recommend, because frankly, it's going to be more painful than letting it heal for a few days. So.
Great, thank you. Question in the chat. Any information on how this may impact someone who already has significant iron deficient anemia? Any update on the patient who is in the treatment and has, watermelon stomach, I believe? I don't know how to say it. Is it GAVE?
GAVE, gave, and watermelon stomach is, if you've seen pictures, is an awfully good description of it. So that's kind of an interesting question for a couple reasons. What was the first half of that again? Sorry.
No problem. Sorry. Any information on how this may impact someone who already has significant iron deficient anemia?
Yes. Okay. Yeah. They weren't related in
sorry.
one way, but is related in another way. So if you have iron deficiency anemia, that's pretty severe, you're probably getting iron supplements by IV. That's the reality in that situation. If that is the case, hey, it becomes very, very straightforward. What they do in these cases is as soon as you finish your TPE treatment, they just turn it into an IV infusion of iron. You've already got the needle in. It's no big deal to do. So that isn't a disadvantage. The level of additional anemia you get from this is pretty mild. The fact that you can typically according to the research literature, like popping a couple iron pills a day is totally sufficient to control it. This is not a real severe. I can explain exactly why it occurs if anybody's interested, but anyway, it's not a major kind of thing. And if you're already getting iron infusions, it becomes easier. You just make it part of your treatment cycle. So you don't even have to get poked again. The watermelon stomach, which is directly related, because that's one of the things that can lead to that. One of the patients, which I have not been able to talk to for a while, has that. And her GI symptoms were getting better. And that was one of the things she was going to talk to her doctor about. But I have not heard from this patient. Frankly, I worry about any patient I can't get a hold of in this era of COVID. For obvious reasons. So hopefully she's fine and, she just changed her email or whatever. For theoretical reasons, I would expect that this would help with that condition. But one of the things I do tell people very upfront, because we have data on this, is that while you might get very rapid relief of Raynaud's, and several patients have reported that they started after the first round, they saw the Raynaud's get much better, and there's research support for that. I presented a poster at the American College of Rheumatology meeting in 2016 on this. That's well known to improve Raynaud's and digital ulcers quite quickly, and there's reason for that. But stomach things, GI is slower. And one of the questions I asked about a year ago, I was very curious to know what happens when people have stem cell transplants with GI, because that's not really in the research literature. And what I learned is anecdotally, not everybody sees complete relief, but when they do, it takes a while, like 18 months before you get major improvements in GI symptoms. That is exactly what my situation was. And the reason we think that is the case is because what probably is happening is the GI tract is slowly rebuilding itself, and that takes some time. So for that reason, I think it's possible that it may help with GAVE, but we don't have objective data. If this patient improves and they go in and see that the GAVE is improved or gone, that's an extremely powerful argument for considering this, but we don't have that data yet. My hope is by the time I do the presentation in May for the case series, we may have an answer to that question, at least preliminary answer, but that is going to take a while. And I mentioned lung improvements take even longer, which is totally consistent with what we know about people who stop smoking and things like that. Lungs do heal, but not quickly.
Thank you, Ed. What research has been done with calcinosis and TPE or PPE?
I've been asked that question a number of times, and the answer is I do not recall seeing a single mention of this in the 46 papers I reviewed for the review paper. I don't know why it is not discussed. I don't have data from any of the patients that have started recently. I'm not sure which ones have it. One of the follow-on things I'm going to be doing I'm trying to get a paper submitted for publication, another topic, the blood type survey I did a few years ago. As soon as that's done, I have an assistant that is going to work with me, and we're going to start trying to pull together much more detailed information on everybody who's on a protocol, sort of background work for the case series. So, but we'll be able to figure out which ones have it so we can follow that. It's a question I'm asked. The answer is I don't know. And, but I expect to know within probably another 6 months, because if we have people who have that as a major problem, it's going to take a while to definitively say they're not experiencing it anymore. So I don't have a good answer to that. And I was surprised to see that one never mentioned in any of the papers we reviewed.
Yeah, interesting. Thank you. A question is, do your nail fold capillaries return to normal?
That's a very, very good question. With a patient in Europe, we have pre and post capillary images, which I've deliberately not looked at any of that stuff yet, but I will. In most cases, we don't have that. There is research showing improvements in nail fall capillaries with TPE. In my case, needless to say, back in 1993, we didn't do high magnification nail fall capillary imagery, but I do have it now. And what we know, in my case, I have very minor nail fall capillary damage to my left little finger, my left ring finger. The rest of them are normal. And that doesn't surprise me at all, because this particular protocol is designed to keep you on the edge of becoming symptomatic. You don't want to do it more often than you have to keep things under control. And that is why if you go off it for a couple of months, you'll start seeing your symptoms return, totally consistent with the treatment model that we're looking at. And so what I expect we'll see when we start getting data on capillary stuff, and believe me, any clinical trial, that will be part of it. We will do high magnification nail fold capillary analysis pre and post. What I expect is that the nail fold capillaries will significantly improve and probably never go quite back to normal, because you're living on the edge is the way I like to describe it. That's actually going to probably be a subtitle of my case report follow-up, is something like living on the edge.
So how do you know how often you have to do this procedure in order to make sure you're living on that edge?
Okay, so this was partly covered in this, when I did the talk last summer, I added some slides. You all saw this, where it shows like image of what goes on with red blood cell clumping. Exact same thing happens with whole blood viscosity, which, by the way, I now have, as I mentioned, I took for 3 months, paid for this out of pocket. I have pre and post blood viscosity measurements, and it's exactly as predicted, as it drops significantly across the treatment cycle and then goes back up. And red blood cell clumping is extremely difficult to measure, so we can't do that one easily. But what we know from a couple studies that were done back in the late 80s and early 90s, where they were really looking at this closely, is what I discuss in those slides, which is, we know that it takes 4 weekly treatments to take blood and go from highly abnormal to completely normal. Now, I'm sometimes asked, but what if you did, the 4 or 5 days apart? What would take? Answer is, having the foggiest idea what the equivalent is. But there's one of the advantages of the 1 per week is it's very easy to tolerate. You don't have any risks that you can get. Like if you do this on a daily basis, then you do have to, then you have some risk, but not on a weekly. What we know is at 4 weeks, your blood is now, according to the research in a fair number of patients, totally normal. The red blood cell clumping is gone, and that's probably why the Raynaud's disappears quickly, mostly. And overall blood viscosity is improved. And by the way, we now know that elevated whole blood viscosity leads to endothelial damage, and it's also part of COVID, which we can talk about as a separate topic. But anyway, what the data that is most important was the 91 paper, Jacobs, where they actually looked at this. And what they did for follow-up, I wish they had done more, is they did the 1 treatment a week for 4 weeks, stopped, and then looked to see what happened to these objective measures. And basically at 3 months after the 4th treatment, which was unfortunately how long it took them to look, the red blood cell clumping was still halfway better than it was before they started, but definitely headed back up. The next data point was 9 months, totally back to pre-treatment. So they really don't have a lot of data. So the protocol that we're using, which is an 8-week gap, which we're saying is a starting point, and we need to do more clinical research to know if we can modify it a little bit. The idea is that 8 weeks you should be heading back toward abnormal, but still be in a range where it's probably doing very little damage compared to what it would be normally. And that's extrapolation. I don't have rigid data points to back that up, but when we've seen it work in a few people now. But so the protocol is kind of designed around that. And one of the comments that I've made and will do in the case series, we recommend that exact protocol for a starting point for the first year. It might be the case that if you've got pretty aggressive diffuse disease, maybe it will turn out that you'll want to do a 6-week gap for the first year or something to be more aggressive on the treatment. And maybe if you have a very slow progression going on, maybe you can go further out. I will tell you, I experimented a little bit, and we know that 2 months, 4 months is too big a gap. We have 2 people now that can testify to that. I actually, this is not in my paper published case report, but we actually, at my initiation, gradually stretched out the gap just to see what would happen. And about 2 years of doing this, I was at a 10.5-week gap. And my index symptom, which is GERD, just started to return, went back on the normal protocol, disappeared pretty quickly. So it looks like this is a pretty good range. Maybe you could do 9 weeks. I've done that for a while. I will tell you that when I missed 2 months, because I was starting to have GERD symptoms, pretty mild, easily controlled. When I went back on, I did a 6-week gap after the first round. I did a 7-week gap after the second round, and about the middle of the second round, my GERD was 100% gone again. And my 4th treatment of the cycle is next Monday, and then I'll go back to the normal 8-week cycle. I'm basically trying to make up for lost ground. But I do think that we have research support saying this is a reasonable starting point, and we really can't stretch it much more than this. You could be more aggressive, but so far we don't think you need to be. Maybe over the long run, we can determine that it does make sense to be more aggressive on diffuse for the first year. Who knows? This is all stuff that once you see that something is basically working in clinical trials, then everybody starts trying variants of the trials appropriately to see what you can and can't tweak.
Awesome. Thank you, Ed. Another question. Has there been any mention of, I can't even say this, telangiectasia improvements? Little red spots.
No, also. 2/3 of the research that was done with diffuse patients, where that tends to be less of an issue than with limited patients. And the other thing is almost all of the TPE studies historically have been pretty short term. So we actually don't know. I never developed them. So I don't know what's happening with that. The patient in Europe had diffuse, early diffuse, and some of you who have diffuse, common early symptoms in diffuse actually isn't Raynaud. In many cases, the initial symptoms, according to Dr. Freck, are severe pain and fatigue. Those are often the very first symptoms of diffuse disease, and which is the case in this patient in Europe. So she didn't have that. One of the things I will be assessing or working, my administrative assistant will working with people who are on it once we get approval from them, is we'll be looking at all these and monitoring more closely. Everyone who is doing this is supposed to be filling out 2 standard research questionnaires at the beginning of each treatment cycle. So we've got, and these are ones that are used widely in research, so they're quite respected. And I actually haven't looked at that for a bit myself, but some of these symptoms and things are covered in these. So we'll have more data when we start looking at it in detail. But the research literature didn't talk about that either. And I think it's partly because very, very few patients were on it really long term. One of the longer term patients was actually a 16-year-old, 17, who had mixed connective tissue disease, which is the case with the 15-year-old who just started the protocol. She was on it for a couple of years, doing absolutely great. Not my specific protocol, but a variant that was working pretty well. It didn't indicate that was one of her symptoms that she was dealing with, to the best of my recollection. I actually called or talked to the author of that case report from about 10, 15 years ago out of curiosity to see whatever happened to this girl, and said she lost her insurance coverage. And so we had to stop, and I never heard from her after that. I can tell you what happened if she lost her insurance. She went back to just normal symptom profile that you would see with mixed connective. So.
That's a good segue. That is one of the questions. Do you recommend a patient check with their insurance company before talking to their doctor?
Totally. And one of the things that's in the slideshow, and deliberately there, if you download the handout version, there are just a simple question that you call your insurance company and ask, and it's, do you cover therapeutic apheresis, CPT code 36514, for the treatment of, and then I have two things listed there. If you have diffuse, the ICD-10 code is M34.0. If you have limited, it's M34.1. If you have mixed connective, it's might be 35.9. I can't remember. I should add that to the slide. But you definitely do want to ask that. We are finding that the vast majority of patients now who call the insurance companies are being told it is covered. Sometimes needs prior auth, sometimes it doesn't. One of the ones that would have been more challenging is actually Kaiser. Kaiser is a very strange group, if any of you have it. But one of the doctors who is just put a patient on is head of rheumatology for one of the major Kaiser places. She's actually already told me that if this works, she's going to put other patients on it. And because she's Kaiser, she'll have a lot of influence. So maybe that'll change. But in the vast majority of cases now, people are told that it is covered. 4 years ago, it wasn't. And why it's changed, I mean, insurance companies, as you well know, always like to become more and more generous in what they cover. We all know that. That's certainly how I think of insurance companies. Or maybe it has something to do with the review paper when that was published in a top journal. I literally don't know, but it is a climate now where very few people have been told that their insurance won't cover it outside of Kaiser. Then the challenge is, of course, the clinician, and I've got some articles talking about that. That's getting easier now that we have more people on it. And especially now that we have at least one doctor and hopefully shortly a couple that will be willing to talk to other clinicians who are considering it. But definitely start with the insurance.
Awesome. Thank you, Ed. That's hopeful for many of us. Another question, you may have already covered this, but someone's asking what the difference is between primary and secondary Raynaud's.
Great question. I actually just had a short letter to the editor published in Clinical Rheumatology last year. A great review paper came out talking about primary versus secondary. It's an excellent paper. And turns out I was actually one of the reviewers. I do peer review for a couple of journals now. And it happened to be a paper I was reviewing. And they totally, the authors of this were totally unaware that fundamentally primary and secondary Raynaud's are completely different. They have the same symptom externally, but in primary Raynaud's, blood is pretty much normal. You don't have damage to the capillary system. In secondary Raynaud's, at least secondary to scleroderma specifically, the blood is quite abnormal. And you do have the damage that's doing it. So it's totally different mechanisms. There's actually some treatments that work with primary, don't with secondary. Like there's some research out there showing in some cases, people have had good luck with hypnosis and things in primary. It doesn't do a thing for secondary. But fundamentally, even though the symptoms are the same, they're completely different diseases. And if you try plasma exchange with primary Raynaud's, and several papers have looked at this back in the 80s and 90s, it does absolutely nothing. And that's because if the blood is not the culprit, which it doesn't appear to be, the fact that this improves the blood had no effect. Whereas in scleroderma, obviously it had major improvements, but they really are completely different diseases. So my letter to the editor, this editor-in-chief of the suggested to me that I would write a follow-up paper, and it's on my list to do at some point. Anyway, but I did do the short letter to the editor pointing out that they really have very different, the blood rheology is totally different in primary versus secondary.
Awesome, thank you. In the chat, 2 questions. One is, how do you recommend we approach our clinician about this? And where can we find a list of consulting doctors?
Well, right now, the list of doctors that have formally agreed to consult is 1. I have another one that I think in 6 months, if she has good results with the patient who started last week, she will definitely become someone. She's been working closely with. Several of the clinicians have not worked with me at all. Several have. She's one who's working very closely with me and on quite a bit of things around this. She's not that familiar with plasma exchange, and I've been able to answer questions and things for her. I have no doubt she'll become someone in hopefully 6 months or so. There's some discussion in one of my things on my website that talks about how to approach a clinician. The reality is the problem you're running into with rheumatologists is they don't use plasma exchange at all. I mean, it's rare for a rheumatologist to have any experience. As a result of this, they have the idea somehow that this is dangerous. It's a last resort. You know, I wouldn't consider it unless we've exhausted everything else, and so forth. So that's what you're typically up against. And whereas some patients actually have hematologists too, and hematologists they use it all the time, so they're comfortable with it. So that's usually the biggest barrier, is a doctor who says that. So one of the things that I now recommend, that if you're going to try to talk to your doctor about this, you first check with insurance, and then what you're going to do is contact your doctor, especially if you can send an email with a couple links. The best thing to do, there is a short overview, it's 2 or 3 pages long for clinicians. We can put the links up with this when you guys post it. That's an overview of pulse plasma exchange for clinicians, and it kind of goes into a little bit and strongly points out the safety profile. And the best approach that seems to have worked is the patient saying, this is something I've heard about, I don't know a lot about it. Could you, there's a couple things here for clinicians. Could you take a quick look and explain it to me and talk to me about it? In other words, put them in a role where they are going to educate you, and rather than saying, here's something I heard about on the internet, I want to try it, that doesn't go over real well. But if you can say, could you take a look at some of this research out there and things, and can we then do a follow-up to talk about it? The clinician is no longer put on the defensive eye roll, yet another Dr. Google educated patient thing. Now, it's not as bad as it was, because a lot of, especially scleroderma specialists, are all very aware of this, whether they agree or not. So there's a little bit more knowledge about it. But the problem is most people don't see experts. They see general rheumatologists who have very little training in scleroderma, as many of you know, and things. So that's really the best approach. The 2 things that I try and get doctors to look at is first the quick overview, and then the handout from my presentation this summer is everything that a clinician really needs to do. They can go through that in 5 minutes and get a very good overview, but in quite a bit of detail. And so those are the two things, but the approach you're looking at is not, I want to try this. Would you read these and can we set up a session to talk about it? From what I've heard, it is very, very safe, or I've had bad reactions to blah, blah, blah. You know, there's different approaches on an individual basis, but one of the biggest arguments you're really headed towards is because this is very safe and because you've already determined that your insurance covers it. When you go into this, you're trying to get into the why not try it discussion rather than the why try it.
Sorry, I was writing a note.
No
That
problem.
was great. Thank you. Let's see. It's kind of on the same subject. It's a long question. I'm going to try and break it up here. Are you able to publish any documents on your website that shows the number of patients on the treatment and their improvements in symptoms or not? Not listing their names. It says perhaps updating often as patients continue with the treatment. Just wondering if this information might help us in talking with clinicians to show them the treatment activity across the US. Or do you think this information is better to wait until a clinical trial is done? Perhaps clinicians would give enough weight to this kind of early tracking.
Okay, great question. The best answer is halfway between those two. For a whole slew of reasons. I mean, one of the things that allowed me to do everything I'm doing is I actually have 4 years of graduate training as a researcher from a really, really intense program. So I actually am very thoroughly trained in doing research. And one of the things that I knew when I made the decision 7 years ago now to start looking at the research aspect of this and seeing if I could maybe get other patients to at least try it. I knew that the only way that was going to occur was doing it exactly the way that researchers have to, which is publish papers. And putting something on the website, doing what you're describing on kind of an ongoing basis is totally intuitive and would absolutely kill any credibility that I would have as a researcher. So I absolutely cannot and won't do anything of that kind of level of detail. Now, what I can do is periodically indicate, so at the point that I get accepted to, let's say, present this research poster next May, at that point, I think I'm not sure when, I might be allowed to say more. I have to find out what I can and can't say on that. But I can at least at that point indicate that this has been accepted. There'll be a poster presented at this conference. At the time that this was submitted, there were X number of patients on a protocol ranging from 1 week to 27 years. And then at the time, later on when I can just kind of do an update. But the only way that I can do it is through publication. And one of the commitments I made several years ago is anything that I publish will be published open access. So anybody can freely access it. That's not cheap. It was several $1,000s to do that for the review paper. The blood type survey that I'm trying to get published now is a couple thousand. I mean, anyway, so if necessary, I'll pay through my nonprofit publication fee. So I'll make sure that anything is out there can in fact be made available to clinicians and things, but it's got to be at least at the level of a research poster with clear data that they can look at. And so it's kind of halfway between, as I say. It's not a full-blown clinical trial. Case series is actually very much respected. If it's well done, that's what leads to clinical trials. But we have to at least get to that point where I can do that. I informally on Facebook and so forth, I do talk about the number of patients. The most I could do is on the website to say, just a quick update. At this point, there are X number of patients on the protocol. All but one are in the US. And this is the antibody breakdown and things like that. That's about as far as I could go. Anything I do before somebody completes their 1-year individual trial, I would not put anything down on a kind of formal basis.
Wonderful. One last question. We're going to wrap up recording, and then we're going to do a quick open dialogue, ending on time at 11:30, hopefully. Not hopefully, we will, Ed.
Oh, that's fine. I'm the only thing I have to do is get my coffee, which I haven't gotten yet, but
I totally get that. One last question in the chat. There's two, sorry. How did you get involved in research?
well, if anybody, let's put in the notes for this as when you guys upload it, put the link to my backstory, which actually kind of answers that. As I said, I'm very well trained in research, not in medicine. Actually, it's research clinical psychology is my degree. I actually happen to be a clinical psychologist, never practiced because I'm also a software entrepreneur, and that ended up what I did as a career. But I do have the research training from that. The decision to actually do what I'm doing now started 7 years ago in October. This is it's a funny story. October 2013, my youngest son said, Dad, I just took a look at the Wikipedia article on Scleroderma, and it's really bad. Why didn't you update it? And I mumbled and grumbled and said, well, there's okay. I at that point was not updating my website because there's good information. Scleroderma Foundation has really good information. There's a couple, Mayo, others have that. So I didn't feel the need to keep my, initial Scleroderma fact updated and hadn't touched it for years. And I made the mistake of saying, tell you what, let me spend a couple of weeks, I'll update the fact, and then I'll go ahead and update the Wikipedia article after I've done that. Well, that's October. So 6 months later, the main document was now up to 46 pages from 14. And Scleroderma Foundation actually reviewed that version because I'd worked with them in the past. And everything kind of started from there, because what I quickly realized is that while there's a lot of information out there, excellent stuff like on the Scleroderma Foundation Mayo, most of it is either pretty elementary, or you better be at least somebody with the medical training, or you're not going to be able to get past the first paragraph. And so one of my goals and what I realized is needed is something that straddles that. So one of the things I've been told I do pretty well is I can take complicated medical stuff and explain it. And that's what the various things on the website are designed to do. And once I got the new website and nonprofit going, I realized, I think survivor's guilt was getting to me even more at that point. And I decided, there must be some way we can get other people. And I realized I had to do it right. And that's what led to my going into research mode and starting to publish. By the way, the Scleroderma Foundation gets credit for my doing that indirectly. When it's a funny story, but when I submitted that 46-page document version of the fact for the Scleroderma Foundation to review, I'm told it was an interesting meeting of the medical advisory board when they were going through that, because at that point I was, just a patient, quote unquote. But anyway, there were two things they did not like in that. One was antibiotic protocol discussion I had in there, and the other was my discussion of plasma exchange. And the comment I got back was, there was one study done in blah, blah, blah that showed and so forth. And at that time I knew of about 12 studies. So I was irritated and decided to take a look. That's what led to my ultimately doing to the poster that I presented at the Freezes. I was just annoyed by that. And ultimately we found 46 papers rather than one. But that actually put me into research mode, because I realized once we start publishing, and I went through the literature we had a strong enough case because of the combination of the research that was out there, half of which was not very good, typical. There was enough research support for clinicians to consider taking it seriously, that it should be looked at, and the safety data was strong enough to say, why not? And so that's kind of led to my continuing and trying to get more and more stuff out there by publications and conferences and the way that you have to get clinicians to accept it.
Awesome. Very last question. Someone's asking, is there anyone in Europe doing what you do?
Well, there's one patient in Europe who's on the protocol. Are you asking clinicians or patients? I'm not sure I understand the question.
I think clinicians, if I'm reading it right, but Lori and Stan, is that correct? Yeah, clinicians.
Okay, so yeah, and not yet. There's a lot of patients that are trying to talk their clinicians into trying it. Certainly the doctor who ordered it for the patient in Europe, but he's actually not a rheumatologist and doesn't normally deal with this disease. But the best chance would probably be Italy, because this is a standard treatment in Italy, not used like this. And I kind of been trying to talk them into trying this with some patients and haven't had any luck in it. I know that I've had some pretty good contact with a couple researchers in there. But in any case, nobody is yet doing it. But I think if we can get a good solid case series, that should allow this to be easier to work better or be more acceptable. By the way, the word series that I keep saying triggers Siri on my computer. I just figured out why it kept popping up. It's kind of funny. I'll have to turn that off if I'm doing another talk like this.
Oh, that's awesome. Ed, thank you so much for participating and coming today and sharing your wealth of knowledge and information. It's very exciting information.
Always happy to help, and I really appreciate the follow-up invitation. It was, it would have been fun to go there in person if we were not in the middle of a pandemic. But the nice thing about these Zoom formats is more people can get access to them.
Yes.
And so, for example, the conference that I'm talking about attending, when I talked to them recently, they're thinking even though it'll be May, they expect it to be virtual. And so it'll actually make more people that will be able to attend who wouldn't be able to afford going to it. So there's some real advantages of having either virtual, or in the future, I think you're going to see conferences will be combined virtual and in person, which I think is a great solution. I think we've learned a lot in the pandemic and things. And there are some actually really interesting similarities between scleroderma and COVID that'd be kind of fun to talk about as well. But and there's actually a role for plasma exchange in COVID, turns out. Another discussion.
Oh, awesome. Well, maybe we'll have you back another time. That's awesome. I guess we're going to finish the recording. We'll stop recording and then we're just going to open it up. We have